Good evening. I'd like to welcome all of you to the symposium this evening entitled Best Practices in ICU Sedation, Evidence-Based Approaches to Management. My name is Dr. Julie Barr, and I am currently the chair of the American College of Critical Care Medicine's task force charged with creating the pain, agitation, and delirium clinical practice guidelines for adult ICU patients. I'm also an associate professor of anesthesia at Stanford University and the associate ICU medical director at the VA Palo Alto Healthcare System. Before we begin our presentation tonight, I would like to thank Hospera and the France Foundation for giving us the opportunity to speak with you this evening on this important topic. A few housekeeping items before we begin. First, please save all of your questions for the Q&A session following the last presentation of the evening, at which time the three panelists will come to the stage together to address your questions. There are Q&A cards located in the center of your tables. Ushers will come and collect the cards after each presentation. Second, there will be a pre- and post-test for you to complete this evening. We will conduct the post-test immediately following the last presentation and before the Q&A session begins. Finally, each of you should have a workbook of tonight's presentations, a copy of the pre- and post-tests, and an evaluation form at your seats. Please complete the evaluation form and turn it in before you leave this evening. I'd like to take this opportunity to introduce the other two panelists this evening, Dr. Richard Riker and Dr. Michael Murray. Dr. Riker is currently professor of medicine at Tufts University School of Medicine in Portland, Maine, and a current member of the ACCM's Pain, Agitation, and Delirium Clinical Practice Guidelines Task Force. Dr. Murray is currently a professor of anesthesiology at the Mayo Clinic in Rochester, Minnesota, and a colonel in the U.S. Army Reserve Medical Corps. He is also a member of the ACCM's 2002 Sedation and Analgesia Clinical Practice Guidelines Task Force. Tonight, I will be providing an overview of strategies for implementing the soon-to-be-published 2013 version of the PAD guidelines in your ICUs. I'm happy to announce that I have absolutely no commercial affiliations or conflicts of interest to disclose as they relate to this topic, but I am passionate about helping organizations improve the management of critically ill patients in their institutions, which is why I'm speaking with you this evening. By the end of these three presentations, you should have a clear understanding as to what the best tools are for assessing pain, sedation, and delirium in adult ICU patients, the best strategies for managing pain, agitation, and delirium in these patients, and the expected synergistic benefit of applying the ICU PAD care bundle in your ICUs. The last version of these guidelines, commonly referred to as the Sedation and Analgesia Guidelines for adult ICU patients, were published over a decade ago. Over the past 10 years, we've learned much about diagnosing and managing pain, sedation, and delirium in critically ill patients. I'm happy to report that the recently revised version of these guidelines, known as the Pain, Agitation, and Delirium, or PAD guidelines, has now been accepted for publication in the journal Critical Care Medicine with the target publication date of January 2013. Given the ubiquitous nature of pain, agitation, and delirium in critically ill patients, we believe that these guidelines will be transformative in terms of their impact on ICU patient care, perhaps even more so than the sepsis guidelines have been. But the full impact of these guidelines will only be realized if they are widely adopted and implemented in an integrated fashion. We are here tonight to give you greater insight into the significance and potential impact of implementing the 2013 PAD guidelines in your ICUs. This version of the guidelines is significantly different from previous versions in terms of the methods used, the content, and the scope. Throughout the process, we had the assistance of a professional librarian, Charles Kishman from the University of Cincinnati. The use of a medical librarian was invaluable to the PAD guidelines process in several ways. He expanded and standardized our search methodology by identifying appropriate mesh terms corresponding to our lists of keywords. He systematically searched the same 8 clinical databases for all of our questions. He served as our database manager, overseeing the web-based RefWorks database, which now includes over 19,000 related references and was accessible to all members of the task force throughout the guidelines process. Overall, the use of a professional medical librarian ensured that the literature search process for the PAD guidelines was both consistent and comprehensive. The GRADE method was used to develop all of the statements and recommendations included in these guidelines. GRADE is an acronym for Grading of Recommendations, Assessment, Development, and Evaluation, originally developed in 2000 by Gordon Guyatt and colleagues at McMaster University in Hamilton, Ontario, Canada. Over the past decade, GRADE has become widely adopted as the standard for evaluating the literature and developing clinical practice guideline recommendations. The use of GRADE has provided added value to the guidelines development process in several ways. The GRADE method allows for a more rigorous and transparent approach for developing statements and recommendations. This helps to minimize the effects of conflicts of interest on the overall process. GRADE also takes into account the relative risks and benefits of a potential intervention in addition to the strength of the evidence, which makes for more practical and clinically applicable guideline recommendations. Finally, GRADE does not allow for expert opinion to be used in the absence of evidence, which enables us to make more robust statements and recommendations. The voting process was also unique to these guidelines. Polling on all statements and recommendations was done anonymously using an online e-survey tool, which was managed by an FCCM staff member. Standardized voting thresholds were used to achieve consensus on all statements and recommendations. This version of the PAD guidelines includes a rigorous assessment and comparison of the psychometric properties of pain, sedation, and delirium monitoring tools, including a comparison of scale design, validity, reliability, feasibility, and their relevance in critically ill patients. Recommendations are also more patient-centered, integrated, and interdisciplinary in their approach, with less emphasis on recommending specific drugs in certain clinical circumstances. Finally, there is greater emphasis placed on the pathophysiology, risks, and management of delirium and its relationship to pain, sedation, and outcomes in critically ill patients. The 2013 PAD guidelines are more comprehensive, with nearly twice as many statements and recommendations as the previous version. The PAD guidelines are also the most comprehensive set of ICU guidelines ever published since the 2008 sepsis guidelines, which were previously considered to be the mother of all ICU guidelines. Due to a lack of evidence, many important questions remain unanswered in this version of the PAD guidelines, which creates possibilities for future research in many areas. The PAD guidelines consist of a series of evidence-based statements and actionable recommendations. The strength of evidence behind all statements and recommendations has been rigorously evaluated, taking into consideration study design, quality, quantity, consistency, and directness or applicability of findings to ICU patients. Based upon this evaluation, the overall quality of evidence is ranked as either high, moderate, or low. Recommendations may be either strong, weak, or none, and be either in favor of or against an intervention. For actionable items, the strength of a recommendation takes into account not only the strength of the evidence, but the net health benefit to patients in terms of the risks and benefits of each intervention as well as the burdens and costs. This process allows for strong recommendations to be made based upon weak evidence and vice versa. In the absence of sufficient evidence, or if the evidence has been conflicting, then no recommendation is made. Throughout the guidelines, we have consistently used the phrases "we recommend" for all strong recommendations and "we suggest" for all weak recommendations. For the past several decades, the standard of ICU care has been to keep critically ill patients in a drug-induced coma until they had sufficiently recovered from their acute illness. Only then did we lighten their sedation for weaning and possible extubation. And it was certainly considered unsafe to significantly move intubated patients, let alone get them out of bed and walk them around the ICU. We now know, however, that most ICU patients can be safely maintained at lighter levels of sedation and actively mobilized even while they are still intubated in the ICU. There is also a substantial body of high-quality evidence which demonstrates that deep sedation of ICU patients, although seemingly benign in the short run, is associated with significantly worse clinical outcomes, including longer duration of mechanical ventilation, a higher incidence of delirium, longer ICU and hospital lengths of stay, higher in-hospital mortality rates, and a higher incidence of prolonged physical and cognitive dysfunction after ICU and hospital discharge. We also now know that linking pain, sedation, and delirium management protocols with ventilator weaning trials and early mobility protocols results in synergistic improvements in ICU outcomes. Over the past 17 years, our understanding of how ICU outcomes relate to the management of pain, agitation, and delirium has grown exponentially. In the mid-1990s, Wes Healy and colleagues first demonstrated that the use of an RN-RT-driven protocol for performing spontaneous breathing trials in ICU patients resulted in a shorter duration of mechanical ventilation. In 2000, J.P. Kress demonstrated that daily sedation interruption reduced both the duration of mechanical ventilation and ICU length of stay. In 2005, Breen and colleagues demonstrated that consistently targeting a light level of sedation achieves similar reductions in the duration of mechanical ventilation as daily sedation interruption did. In 2001, we learned that the prevalence of delirium in critically ill patients was over 80%. In 2004, Ely's group demonstrated a 10% increased risk of death at 6 months for every day a patient was delirious in the ICU. In 2007, Bailey demonstrated the safety and feasibility of an early mobility protocol in mechanically ventilated ICU patients. But when the last version of these guidelines was published in 2002, the relationship between spontaneous breathing trials, spontaneous awakening trials, delirium, and ICU outcomes was unclear. Over the past 5 years, several studies have demonstrated synergistic improvements in clinical outcomes when analgesia and sedation regimens targeting adequate pain management and light levels of sedation are linked to spontaneous breathing trials. The ABC trial, published in 2008 by Gerard and colleagues, showed that by combining spontaneous awakening and breathing trials in the ICU, they reduced the duration of mechanical ventilation by an average of 3 days, ICU and hospital length of stay by 4 days, and decreased the risk of death by 32% in these patients. In 2008, Peter Morris and colleagues showed that by linking the ABC protocol with an early mobility protocol, that ICU length of stay was further shortened by an average of 1.4 days and hospital length of stay by 3.3 days. Finally, in 2009, Schweikert showed that an early mobility protocol linked to a spontaneous awakening trial in the ICU was associated with significant reductions in delirium and nearly a 3-fold increase in the likelihood of patients achieving an independent functional status at the time of their discharge, meaning that more of these patients could go home from the hospital instead of to a skilled nursing facility. In 2010, Vasilevsky's captured the essence of this integrated approach to PAD by coining the phrase ABCDE bundle, which stands for Awakening and Breathing Coordination, Delirium Prevention and Monitoring, and Early Mobility and Exercise. Improving the management of pain, agitation, and delirium is not about finding a magic drug or a smart box to improve the care of our patients. It's about making the care that we deliver more patient-centered and to more fully invest ourselves in this process. Implementing the recommendations put forth in the PAD guidelines requires an integrated, interdisciplinary, team-based approach, which includes early adopter representation from all stakeholder groups, including not only ICU physicians and nurses, but respiratory therapists, pharmacists, physical therapists, hospital administrators, and ICU patients and their families. Perhaps most importantly, a team's success in implementing these guidelines will depend upon the presence of a physician champion for each and every ICU, someone who can lead by example to inspire the masses in the middle to move towards an integrated approach to managing PAD in all ICU patients. This team approach requires a significant investment in time and effort, but this is time and effort well spent in terms of improving ICU patient outcomes. How much money would your hospital save if it could significantly reduce patient ventilator days and reduce ICU length of stay by 2 to 4 days? How many more patients could you care for in your ICU by opening up more beds? How many more of your patients would survive both their ICU and hospital stay and return to a high quality of life after discharge? And how many of your patients would prefer to go home after surviving a life-threatening illness? This is the ICU PAD Care Bundle, which serves as a roadmap for implementing the PAD guideline recommendations and will be published as part of the 2013 PAD guidelines. The key to successful implementation of this bundle is to break it down into steps. Initially, on implementing monitoring tools, then implementing treatment protocols for managing pain, agitation, and delirium using both non-pharmacologic and pharmacologic strategies that match your ICU patient populations. And finally, integrating these treatment protocols with spontaneous awakening trials, spontaneous breathing trials, early mobility programs, and environmental management strategies to prevent complications of oversedation and to maximize the benefits to ICU patient outcomes. Ultimately, once you have implemented all of the major elements of the ICU PAD Care Bundle, the remaining challenges for your ICUs will be to ensure that your ICU pain, agitation, and delirium protocols are seamlessly working in coordination with one another, and to ensure that there is a high level of compliance with all bundle elements in all of your ICUs. Successful implementation of an integrated ICU PAD Care Bundle starts with the use of valid and reliable tools to assess pain, agitation and sedation, and delirium in critically ill patients. Oversedation of ICU patients often results from the fact that we use multiple drugs to treat an agitated patient because we're not really sure why he or she is agitated. We may assume that an agitated patient is delirious when the patient may actually be in significant pain, even if they haven't had a surgical procedure. We may assume that an agitated patient needs more pain medication when they actually are just anxious because they don't understand what's going on, because they can't see without their eyeglasses or they can't hear without their hearing aids. We may assume that an agitated patient is merely undersedated because of growing tolerance to their sedative agents, when they may actually be delirious due to the sedatives themselves. Using validated bedside assessment tools to assess pain, sedation, and delirium separately enables clinicians to correctly identify the cause of a patient's agitation and to treat them more effectively. The next step is to then incorporate these PAD assessments into your daily ICU care plan. Every day on ICU rounds, the following questions should be addressed at the bedside by the ICU team. What is the patient's current pain score and analgesia regimen? What is the patient's current and target sedation scores and their current sedation regimen? What is the patient's delirium score and what are their delirium risk factors? Performing these assessments without using this information to facilitate clinical decision-making will result in a failure to realize the full potential benefits of the PAD care bundle in your ICUs. This information should then be used to appropriately target treatments for pain, agitation, and delirium using treatment protocols consistent with the culture of your units. The PAD guidelines do not propose a one-size-fits-all drug treatment strategy, but the treatment goals should nevertheless be the same. First, optimize pain management in ICU patients by assessing and treating pain first, then sedating patients. Treat all significant pain as defined by either a numerical rating scale or a behavioral pain assessment tool. Employ an appropriate analgesic treatment strategy that's tailored to individual patients to effectively treat their pain. And finally, treat ICU procedural pain preemptively. Second, optimize sedation management by sedating patients as needed with sedative hypnotic while maintaining a light level of sedation in patients through the use of sedation protocols that either target a specific sedation score or daily sedation holidays. In the PAD guidelines, we define a light level of sedation as one that allows ICU patients to be responsive, aware, and to purposely follow commands. Specifically, the ability to purposely follow commands includes a combination of any three of the following actions upon request. Open your eyes, maintain eye contact, squeeze your hands, stick out your tongue, wiggle your toes. This level of sedation allows for ICU patients to be assessed for the presence of delirium and to participate in ventilator weaning trials and early mobility protocols. It's also important to choose sedatives that minimize patient side effects based on their pharmacologic profile. Finally, optimize delirium management using both non-pharmacologic and pharmacologic strategies. Make sure that delirious ICU patients are receiving adequate pain treatment. Reorient ICU patients frequently and make sure that patients have access to their eyeglasses and hearing aids if needed. Avoid benzodiazepines use in ICU patients who are currently delirious for reasons other than ETOH or benzodiazepine withdrawal, and use antipsychotics in these patients judiciously. Finally, implement strategies to prevent pain, agitation, and delirium from occurring in ICU patients. This includes linking spontaneous awakening trials to spontaneous breathing trials to facilitate weaning from mechanical ventilation. Linking spontaneous awakening trials to early mobility and exercise protocols to reduce ICU delirium and to improve muscle strength in patients. Implement environmental controls to protect patients' sleep-wake cycles to reduce delirium and to improve sleep. Although there are exceptions to each of these rules, this ICU PAD care bundle should be fully applied to most ICU patients, with providers being allowed to opt out rather than opting in their patients and then documenting their reasons for doing so. So how do you know if your ICU PAD protocols are working? Once your PAD protocols are in place, it's important to monitor the adherence and effectiveness of these protocols in order to maximize their benefits. Tracking performance will also enable teams to better understand barriers to performance improvement and to identify new strategies and test their effectiveness at the bedside. These are suggested metrics corresponding to each element of the ICU PAD care bundle, which will also be published in the 2013 PAD guidelines. The effect of implementing the PAD care bundle on broader ICU clinical outcomes, such as duration of mechanical ventilation, ICU and hospital length of stay, and mortality, should also be monitored in your ICUs in order to demonstrate the value of these protocols to ICU staff and hospital administrators, and for ensuring sustained buy-in and protocol compliance by all stakeholder groups. To facilitate the widespread adoption of these guidelines, the FCCM has plans for developing a web-based PAD toolkit, which will potentially include off-the-shelf PowerPoint presentations to facilitate staff education on the PAD care bundle, instructional videos demonstrating how to properly perform bedside pain, sedation, and delirium assessments, and how to safely mobilize ICU patients, pocket cards summarizing the PAD guideline recommendations, smartphone and tablet apps to facilitate education and application of the PAD guidelines at the bedside, templates for ICU PAD checklists, goal sheets, and order sets, and sample PAD protocols. As potential early adopters of the PAD guidelines, your efforts in developing effective implementation tools will help us to develop useful web-based tools for others to use as well, and we welcome your input. These guidelines move the focus of managing pain, agitation, and delirium back to the bedside of our patients. It gives us the opportunity to bring the humanity of our patients back into our practice and to significantly improve their lives beyond their stay in the ICU. The last 10 years of critical care practice have focused on implementing the sepsis bundle. Let this be the decade of the PAD bundle. Thank you for your help and consideration. I'd now like to introduce Dr. Rich Riker.